Everybody's fine. Hello, everyone, and welcome to the new iWiMS meeting of the Epidemiological Working Group. Today we have two speakers. First, we're going to have Alice Saul. Alice, she's a doctor, a postdoctoral research fellow who has worked during 9 years in the MS field. She has gained substantial experience in project management and has worked as project officer and database management on various epidemiological studies. She has obtained her doctorate studies in the University of Tasmania's Menzies Institute for Medical Research in 2023, where she focused on the role of diet in MS. That is the project that she's going to present today. She has also worked in different subjects related to MS, such as stress, depression, anxiety, and fatigue. And she has received an MS Australian postdoctoral fellowship to explore the role of chronic pain in MS. In recognition of her multiple achievements, she has received the Golden Keys 2018 Asian Pacific Postgraduate Study Award. And in 2019, she was also honored with a MS Australian Postgraduate Scholarship. She's currently serving as the academic lead at the Understanding in MS Massive Open Online course. So thank you very much. Alice is going to speak, as I said, about a pro-inflammatory diet in people with MS. If pro-inflammatory diet is associated with an increased rate of relapse and increased FLAIR lesions volume on MRI. And she's going to talk about this very interesting study. Thank you very much, Alice. You can now start.
Thank you, Anna. Good morning from Tasmania, Australia, everybody. As Anna mentioned, my name is Alice. And this paper, the presentation of mine today is I'd like to share some results from a paper I wrote during the PhD when we were examining the role of diet in MS. So just in case that we have anyone on the call that is new to MS, MS is a chronic autoimmune disease typically diagnosed between the ages of 20 and 50. It occurs when the immune system mistakenly attacks the protective covering of nerve fibers called myelin in the central nervous system. And it's this damage that disrupts the transmission of electrical signals, leading to various neurological symptoms, often leads in physical, cognitive, and emotional impairments. It's estimated around 2.8 million worldwide are living with MS, and the exact cause is unknown, but it is believed to be a combination of genetic and environmental factors. One of these environmental factors that has been researched is inflammatory diets. Now, inflammatory diets refer to eating patterns that promote inflammation in the body and are forced to contribute to chronic inflammation in the central nervous system. So we know that inflammation is a very natural immune response, but it's this chronic inflammation that's generated over time that's been linked with the development of various health conditions, such as cardiovascular diseases, type 2 diabetes, and certain cancers. Now, inflammatory diets may contribute to chronic inflammation by triggering sort of like an imbalance in the body's inflammatory processes. This leads to a loss of, it's thought to lead to a loss of a self-immune tolerance, and then it's at that major amplification in CNS inflammation. Now, the Dietary Inflammatory Index is an indice that was developed to assess this potential of diet to cause inflammation. So the Dietary Inflammatory Index was created by Dr. Nitin Chippa and colleagues from the University of South Carolina. It was aimed to be universally applicable, and it is, so 3 possible values were assigned in the indice of +1, -1, and 0, and these refer to a certain food parameter on a questionnaire, such as a food frequency questionnaire, of a food that was of inflammatory properties, such as whether the food was pro-inflammatory, low inflammatory, or no effect, respectively. Now, there's 2 sort of types of indices that our friends from South Carolina created for. They can create a total dietary inflammatory score and a score using an energy-adjusted global database, EDII, that is referred to as short. So I'm often asked when I was doing my PhD, what actually is an inflammatory diet? And typically it was when I was actually eating some quite pro-inflammatory foods, as most of us do when we're generally out for dinner. Common components of pro-inflammatory diets tend to include sugary beverages, refined grains, fried foods, processed snacks, and excessive consumption of red and processed meats. In reverse, anti-inflammatory diets emphasize whole and unprocessed foods such as fruits, vegetables, whole grains, lean proteins, and healthy fats. But it's certain features of these foods that contribute to a higher DII score or more pro-inflammatory score, including saturated fats, trans fats, total energy intake, cholesterol, vitamin B12, and protein. So the literature surrounding the inflammatory diets in MS using the Dietary Inflammatory Index is quite limited. We could really only identify one cross-sectional study that's previously examined the association between the Dietary Inflammatory Index and various MS outcomes, and they found no association between the Dietary Inflammatory Index with the number of relapses in the previous 2 years, level of disability, and presence of GERD enhancing lesions. However, this study had a few limitations. Relapses in the previous 12 years or recent MRI lesions may have influenced dietary intake, so really that reverse causality aspect. An assessment of disability focused on actual disability and not disability progression with considering disease duration. We therefore aim to assess prospective associations between the Dietary Inflammatory Index and various MS outcomes, such as time to relapse, annualized change in disability, fluid attenuated inversion recovery, lesion volume, and black hole lesion volume. And we hypothesised that a more pro-inflammatory diet would be associated with a worsening of MS outcomes. So how we did this is we used data from the Osimmune longitudinal study, or nicknamed the OSLONG study for short, where we recruited in 2003 to 2006 282 people with a first clinical diagnosis of central nervous system demyelination. We've almost followed these participants for 20 years now, but this analysis is focused on data up until the 10-year time point. We collected this data using annual reviews. However, not all measures were captured annually. And we limited the analysis to those who had converted to MS by the 10-year review. Our exposure was diet inflammation, and this was measured at the baseline 5 and 10-year OSLONG reviews. And we captured this dietary inflammation potential using the Dietary Inflammatory Index. So our friends from the South Carolina calculated it using our data from the food frequency questionnaire. And again, they, I mentioned this previously, but they created an overall score and a score created using a food energy adjusted database. Time to relapse, we captured this across the whole study period, and we analysed this using survival analysis. Annualized disability change was measured using the expanded disability status scale, and we captured this at the 5 and the 10-year OSLONG reviews. We used transform linear mix effect models for repeated measures, and then we back transformed the results and presented them on their original scale. With the MRI outcomes, we analysed them in a similar way. In our analysis, we used a FLAIR and black hole lesion volume as a total measure, so total lesion volume, but we also looked at a few different areas of the brain too, such as the juxtacortical, periventricular, and infertorial regions of the brain. So just to give you a little bit of an overview of the characteristics of those in the OSLONG study, 81% of our sample was female, and the mean ages of our sample was 44.5 years at the 5-year review and 48.7 years at the 10-year review. When examining the association between the Dietary Inflammatory Index and relapse risk, we found that those with a dietary inflammatory score of greater than 1.8, which represents a pretty pro-inflammatory diet, were 2 times more likely to experience a relapse when compared to those with more of an anti-inflammatory diet in our sample of minus 3.15 to minus 5.7. There was a significant, test for trend and a dose response present, and this sort of indicates stronger evidence as association between the 2 variables. There was no association when we examined the total juxtacortical periventricular FLAIR lesion volume when we included all the participants. However, our associations became stronger when we limited to those with the same MRI scanner. And when we limited to those that we were sure that it was their first demyelinating episode, or what we like to call a classic FDE. When we limited to those with the same scanner and a classic FDE, we found evidence that a more pro-inflammatory diet was associated with a higher total FLAIR lesion volume. And this association appeared to be driven by the periventricular region. We found no association between the dietary inflammatory index with black hole lesion volume or annualized EDSS change. Now, I haven't shown the data here for that one, but you can view the paper if you wish. It was published in MSJ earlier this year. The strengths of our study were that we were able to capture a long assessment period of 10 years since the first clinical diagnosis of demyelination. So we're able to capture quite complex disease changes during this period. We were able to establish the correct temporality with our exposure, so being our exposure prior to our outcome, when capturing the dietary inflammatory index and lead to our outcomes, so timing of relapse, lesion, and disability changes. Or we performed an analysis to find that no significant changes in our dietary inflammatory scores. There were no significant changes for our dietary inflammatory scores for those with a greater worsening of disease, giving us confidence that reverse causality isn't an issue. However, a big disclaimer, we also can't rule it out. So there is a potential for reverse causality in our analysis. We did have a lower sample size in some of our analyses, reducing power to detect associations. In most of these type of studies, there is always the possibility of unmeasured confounding, despite being able to consider many variables. We also may have potentially missed cases when the revised diagnostic criteria was updated. So the key findings for this paper were that a pro-inflammatory diet was associated with a higher risk of relapse. We also found that a higher pro-inflammatory diet was associated with an increased total and periventricular FLAIR lesion volume. We did not find any association with annualized EDSS change or black hole lesion volume. The take-home messages here today were that an anti-inflammatory diet cannot replace anti-inflammatory medications in MS treatment. And although prospective studies and randomized trials are needed to confirm findings, it suggests that adopting an anti-inflammatory diet may contribute to overall health and the well-being of people with MS. I'd like to acknowledge my supervisors, Professor Ingrid Vandermeer and Professor Bruce Taylor, and I'll also acknowledge Professor Lee Blizzard, a lovely statistician, for his help with this work, as well as Steve Simpson-Yap and the rest of the MS team at the Menzies Institute for Medical Research. I was also lucky enough to be funded by MS Australia as a postgraduate scholarship for this study, so I'd just like to acknowledge MS Australia too. Thank you very much for your time.
Thank you, Alice, for your presentation. We will have time for Q&A at the end of the second presentation. So if you want to make any questions in the chat or afterwards, we will be coming back to you, Alice, for some questions. Thank you so much.
No, thank you for having me.
Thank you. So our next presenter is Akash Virupakshaiah. I hope I pronounce it
You got it correctly.
Perfect, thank you. So he attained his medical degree from the Rajiv Gandhi University of Health Sciences in Bangalore, India. Following this, he completed his residency in pediatric neurology at the Children's Hospital of Philadelphia and the Hospital of the University of Pennsylvania. Dr. Virupakshaiah currently serves as a clinical and research fellow at the University of California, San Francisco, under the mentorship of Emmanuel Mouvant. His research pursuits primarily focus on clinical investigations related to pediatric MS, demyelinating disorders, neuroimmunology, and participation in clinical trials. And today, he will present about predictors of a relapsing course in a myelin oligodendrocyte glycoprotein antibody-associated disease. Thank you, Akash.
Thank you for the kind introduction, Ethel, and I want to thank the iWiMS for having me present my recent paper on MOGAD, predictors of MOGAD in children. These are, just want to confirm, can you all see my screen?
Yes, perfectly.
Okay. These are my disclosures. The funding to the pediatric MS network was provided by the NMSS, and the testing for some of our patients was made possible by the R01 to Owen Flanagan from the NIH. So there are 5 distinct demyelinating disorders that affect the central nervous system, and most distinctly and very well characterized is the multiple sclerosis. And the second well described is aquaporin 4 IgG associated neuromyelitis optica spectrum disorders. And more recently, although we have known it for a while now, but recently considered as its distinct, as a distinct entity is myelin oligodendrocyte glycoprotein antibody-associated disease, or MOGAD, and a subsection of ADEM, for which the cause still remains unknown, and idiopathic optic neuritis. Understanding pediatric MOGAD is essential, as it attributes to about 50% of all the cases of MOGAD, and the known literature suggests that about 50% of these cases are relapsing. The phenotype in pediatric is also quite distinct from what we generally see in the adult literature. ADEM is a predominant phenotype in children younger than 11 years of age, and after 11, it's mostly optic neuritis or transverse myelitis as the common phenotypes. A recent study from Armang and Armang colleagues published in Lancet also showed that MOG-IgG is the most commonest, or the most common antibody associated with pediatric autoimmune encephalitis. And at this time, especially in pediatric MOGAD, there's limited data in understanding the predictors of relapse, and there are no randomized controlled trials that have shown any specific findings on acute and chronic treatment, although some are on their way currently. So we aimed to identify predictors of relapse at onset. So the data was collected from the 13 participating sites from the US Pediatric Network from across the US. The inclusion criteria for our study included being positive for MOG-IgG by cell-based assay, negative for aquaporin 4 IgG by cell-based assay, and these testings are performed at the Mayo Clinic. Having a diagnosis of CNS demyelinating disease in the database, which was not MS or NMOSD, and pediatric onset, which we defined as less than 18 years. And we identified 326 MOGAD cases. The network collects the data on all of its patients using a standardized questionnaire, and the data has been entered from 2011 until August thus far. So it's a prospectively entered data, although the study was a retrospective study. The main outcome measure we tried to assess was the time to first relapse, and we used a univariable Cox regression to identify predictors of relapse, and multivariable Cox modeling was used to adjust for confounders to identify the predictors. We included demographic predictors and also what stood out in the univariable analysis, and also used our clinical judgment to include the predictors exposures for multivariable regression. Multiple imputation was applied for the missing data. So this is the table 1, or the summary of the demographics and clinical characteristics of MOGAD in our cohort. It's slightly female predominant, and the kids were slightly younger compared to other children with MS and NMOSD from the data that was available from the other papers published from the network. And about 46% in this cohort had a relapsing course during the mean follow-up period of 3.9 years. And this is a forest plot that shows the univariable analysis. As you can see, the demographics, the female, Hispanic ethnicity, and non-white race were associated with a higher risk of having a relapse. And these are their corresponding hazard ratios. I'll talk about steroids in a minute with the Kaplan-Meier plots. And here is the univariable analysis for sex and ethnicity that shows higher risk of relapse with female and Hispanic ethnicity. The same thing goes with the non-white race, and the phenotype did not show any significant predilection. So in the univariable analysis, what we found was that using no steroids as a reference point, the patients that did not receive acute pulse steroids at the time of onset was associated with a higher risk of relapse compared to those who did receive steroids. And the patients that did receive a taper had a higher tendency of performing or had a higher risk of relapse than the ones that just received pulse steroids. So this can be better visualized in this Kaplan-Meier plots. The green curve represents the patients that received pulse steroids without any taper, and the red are the ones that received pulse steroids with the taper, and the blue ones are the ones that did not receive any taper or did not receive steroids. So this is the multivariable analysis. Would like to highlight that the findings on the steroid did not hold significance in the multivariable model. But the female and the ethnicity, Hispanic, being a female and Hispanic, having a Hispanic ethnicity as your background was associated with a higher risk of relapse. And we also found that anti-CD20 in our study, rituximab and maintenance IVIG that were started shortly after the onset of symptoms were also associated with reduced risk of relapse. And incidentally, we also found that the maintenance steroids before first relapse, which we define in our cohort as being on steroids for more than 3 months, was also associated with a higher hazard ratio. Although it did not meet significance, it showed a higher concern or tendency towards approaching significance to 0.09. We think that the study may have been slightly underpowered, and had we had more samples, this could have met significance. And I could also say the same thing for non-white race as well. So discussion, so sex and ethnicity appear to have an effect on relapse risk in pediatric MOGAD and should be considered in guiding management. IVIG and anti-CD20 that is started shortly after at the first event could help prevent a second event. Although the acute steroids, pulse steroids, was not significant in multivariable model, there was a concerning tendency of using maintenance oral steroids, and this could have a negative impact and could be associated with a higher risk of relapse. Other DMTs were not significant in the multivariable model. Limitations, there could have been some referral bias as all the participating sites are all referral sites, missing data, and some of the treatment could be site-specific and could have influenced our results. Study strengths include, this is a large prospective pediatric cohort, and this is the largest pediatric MOGAD cohort that's reported. And to our knowledge, this is the only first study that has analyzed the data with adjusting to potential confounders. So conclude with demographics could affect the prognosis in MOGAD. And specific DMTs at onset may be considered in those that are higher risk in having a multiphasic disease course. I would like to thank my mentor, Emmanuel Labonte, and the other colleagues that I work with, UCSF, and the rest of the pediatric MS network sites for their continued support. And thank you everyone for your time.
Thank you, Akash, for your presentation. It was very, very interesting. So we will start with the Q&A. If anyone want to make their questions, you can raise your hand or put them in the chat. So Helen, please go ahead.
Yeah, sorry, thank you. There were two really super interesting presentations. So congratulations, both of you. Sorry, I'm Helen Tremlett, University of British Columbia. So Alice, I was interested, are you planning any intervention studies, or is anyone else? And what are your thoughts in terms of challenges in getting people to adhere to the diets? Do you see it as fairly straightforward, or any insights on that?
So I guess I'll answer your first part of the question first. So in terms of RCTs and inflammatory diets, there has been one where in MS outcomes that mainly looked at fatigue, not necessarily progression, to my knowledge. So in terms of myself doing an intervention, I would absolutely love to, and collaborations are always welcome. We would like the evidence base for this to increase in numerous cohort studies before we go down that route. Also, however, we are aware that our Ausong study is luckily very, 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 very unique. Not many other studies have data collected up to the 20-year time point as well. So we're aware that replication is a little bit difficult in some cohort studies also. And your last part of your question, sorry, was about adherence. Yes. Yep. Adherence. Yeah.
Yeah, no, just curious.
Yep.
In terms of, obviously, how straightforward or easy is it, do you think, to enable people to adhere to the diets? I know you kind of summarized, like, globally what the diet was about, but not too much on details, which I didn't expect you to. But I'm just curious, is that, say, in Australia, is that an easy diet for people to adhere to, or thoughts on that?
So in general, adherence in dietary interventions is quite difficult. For an anti-inflammatory diet, it is, I guess we're sort of, and I know that the University of South Carolina are developing a portal at the moment to show sort of what the different foods that you could do to make that more of a translatable outcome at the moment. It is. I guess I don't want to outstep my place as I'm not a dietitian, so I don't want to outstep my place here. It is a sort of a diet that we're learning more about over time, and I guess with an anti-inflammatory diet, I guess it's a bit of a scale of these diets of how easy they are to follow. I wouldn't say it's the easiest diet to follow, but I necessarily wouldn't put it in the impossible basket either. The group at the University of South Carolina have developed a portal which I think is being utilized at the moment, to which that they are sort of assisting people with the different foods that they can follow or that they can implement to represent that anti-inflammatory diet. And that is potentially a tool that you could utilize for interventions. But yeah, it's a bit of a difficult one to answer in terms of the scale of these diets, because I'm aware that, you know, adherence is a very difficult thing to you know, it's a big limitation in dietary intervention studies. So you know, definitely want to make, if you are testing any diet and an intervention, you try and make it as simple as possible, if that makes sense. So there's still plenty of work to be done in terms of formulating this diet, I guess, to be able to be tested in intervention, because we're just so early in the piece. And I guess that's another reason why we'd like a few more studies as well, to be a little bit more concrete in our findings, and also to working out, I guess, indices take into account quite a broad number of foods in their calculation of their mathematics score. So it'd be really interesting. I guess the next step is to work out which foods are more driving this association, and also to making sure that our score isn't correlated, with another dietary score also. So still plenty of work to be done, but we're excited with what we've found so far.
Thank you very much, Alice. Appreciate it.
That's all right.
Thank you, Alice. Emmanuel, if you want to ask your question or comment.
Yeah, so I have 2 questions. The first is quick because I may have missed that because there's a lot of data that were presented. The anti-inflammatory index was actually collected only at baseline, or was it collected like over time as well? That was my
that's all
first
right.
question.
That's all right. So we captured a food frequency questionnaire at the baseline 5 and 10-year Auslong review, and using that food frequency data, that's what we generally send to the University of South Carolina. So it was captured at the dietary inflammatory index was captured at baseline, yes.
And so did you see a lot of changes over time that occurred in patients on in terms of their diets, considering that often we see patients who want to change their diet once they're diagnosed with MS. So did you see any kind of patients mostly sticking to their diet, or did you see lots of changes over time?
So we I guess reverse causality in terms of those with a worsening disease or those that want to change their diet will always be a bit of an issue in these studies. But we did find that at our baseline 5 and 10-year review that our dietary inflammatory index didn't change that much, giving us a lot more confidence in our results. We did capture data on whether those at annual reviews changed their diet also. So we were able to do sensitivity analysis to look at who had changed their diet on a yearly basis also.
Mm-hmm. And so did you include in the questions that were asked to patients other type of indices like the healthy eating index or other indices that have been reported, or the I forgot the one, the glycemic index, or these kind of things?
So as part of my PhD, I examined 3 different indices. So I examined the dietary inflammatory index. I examined 2 measures of diet quality, which is similar to the healthy eating index. So we looked at the Australian recommended food score and the diet quality tracker. The reason we didn't use the healthy index was it was more US applicable. So those 2 scores were more representative of our Australian diets. And the 3rd score I looked at was a measure of diet acid load. So those are 3 different indices that I looked at during my PhD. But there is other work. I mean, there are other indices out there as well that are being studied at the moment, such as the Mediterranean, the DASH. There's many. So yes, I just focused on 3. Ended up being quite a big PhD. So yeah, I stuck with just 3. Thank you for your question.
Thank you, Alice. So we have some questions for Akash. We have a question from Ellen Murray. I don't know if you, Ellen, want to ask it?
I can briefly go over. So
Sorry. Well, I don't see a lot of MOGAD patients, Akash, but my local person always says, like, oh, you have to give a really long taper, at least for, I guess, maybe the adults. And so I was surprised by your findings. And it seems like this would be something that would be really amenable to like a randomization event, where you could make sure that unmeasured confounding, like you mentioned, wasn't contributing to the findings.
Yeah, those are some very good points, Ellen. So I think the standard of care, at least like most places right now, mostly with children, is not to do taper. But we do see sometimes patients that have been on tapers at the time of when they get referred to us. That can take a while. So they are placed on on a very prolonged steroid taper, and they come to see us, and they've been on the taper for over 3 months. But I think there are some people that still believe taper may be helpful versus maybe not. The 2021 Marinier paper they say both ways. Like some experts believe and some experts do not. And there's no convincing evidence as of yet to show until my data came out. So we do think that a trial might be really helpful in considering is this really helpful, because for now what we know is the ONTT data, and there's nothing else. And MOGAD patients in that ONTT data, there were only I think less than 5. So I think a trial in MOGAD particularly could be helpful. And in children, it might also have a different, like the way the biology of steroids is, there could be other comorbidities like obesity, increased adipokine-associated inflammatory markers that could be playing into the inflammation, but it's kind of hard to tell. I think a trial would be helpful.
Yeah, sounds interesting.
And I see another question. Does the clinical picture at onset have any impact on relapsing course? We did not see any specific phenotype that was associated with a higher risk of relapse. Some other smaller studies have shown to be, like for example, ADEM in children less than 10, to be associated with a lower risk of relapse, and a smaller British cohort showing transverse myelitis may be associated with a reduced risk of relapse, but we didn't see those effect in our study. And in regards to the steroid treatment at onset, only in the univariable analysis we found that receiving acute pulse steroids was associated with a lower risk of relapse, but it did not hold true in the multivariable analysis.
Thank you very much, Akash. Do we have any other questions? I would like to ask some question to Alice. Well, as I'm from Barcelona, here we talk a lot about Mediterranean diet. There's quite strong evidence that Mediterranean diet associates to lower cardiovascular risk, and there's a pretty new MSJ paper talking about Mediterranean diet improving some, not EDSS, but I think composite records. Like, would it be possible, like Mediterranean diet versus pro-inflammatory, like the contrary? Is there an option? I'm using it as a standard. I used to say to patients, well, there's not enough evidence of any diet, but now I'm kind of changing, as it's the one that we should be doing around here. I don't know how you feel about that.
It actually touches on something that I wished I had contributed to Emmanuel's question. So I'm glad that you asked it. Thank you. So with these indices, I mean, part of my PhD was to compare the 3 different indices that I looked in my PhD also, and we are finding that, you know, different indices such as the Mediterranean diet are coming out as such as a higher, you know, Mediterranean score, or you know, those who are adhering to that particular diet are associated with a better MS outcomes. So I completely agree with you. I've also actually raised it about a paper to compare these different indices, and you know, for those who are not in the diet space, country of residence and culture tends to play a part in that also. So whether that is just for us, I guess, just more of an Australian-based one, but it'd be super interesting to be able to compare them internationally as well. So yes, I totally agree with you. I think that would be a lovely collaboration.
So I just want to say congratulations for today's meeting, because we were almost 30 participants, which is really great considering that, for example, in the US, it's Thanksgiving week, so lots of people are on vacation. So congrats for a well-run group of interest.
Thank you, Manuel.
And So we've had issues with the database with all the email contacts of the people who had registered with iWiMS. And some people have stopped receiving email. So we're trying to troubleshoot what's happening. But if you are not receiving those emails from the general iWiMS membership, or have stopped receiving them, or are not registered yet, the website has been updated, so now you can go register or re-register, and that would be saved in the new email database, so that it wouldn't hurt if you were doing that.
Thank you, Manuel. Yes.
Manuel.
Yes, we also have our next meeting. So the date will be on February 26th. So you can mark your calendars. We already have one of the presenters. So if you are interested in showing your work, please contact Anna or myself, and we will be happy to invite you as a speaker to the next presentation. And I think we have time for a few questions. I have one more question for Akash. We have a little bit of a mixed cohort in our country of pediatric and adult patients with MOGAD, and we've seen that one of the most important clinical factors for relapsing MOGAD is the duration of the follow-up. Because when you have a very short follow-up, you will have mostly monophasic cohort. But if you're in your study, you have a very long follow-up. And we are finding some adults, patients with MOGAD, that when we ask them about previous neurological symptoms, they tell us that they have like viral encephalitis when they were like 4, or they have 2 episodes of Guillain-Barré syndrome, but now they present with an optic neuritis. Do you have some of the first relapsed with some different clinical courses, or they are all diagnosed with MOGAD in the first episode, or are some of the patients retrospectively diagnosed?
And that is a good question, Ethel. So we have data that has been collected from 2011 until recently. So as you know, that the MOG commercial testing became available like end of 2017, and now it's been almost like at least many centers do it on a regular basis. So for the patients that were diagnosed previously, or that presented with their first symptoms initially, we had banked their serum, and eventually they underwent testing on a research basis, and then they were positive, and they were reclassified into MOGAD. And if you go back and look at their chart, some of them are like in the early 2000s too. They usually are diagnosed as viral encephalitis or ADEM of unclear etiology, and then subsequently we found that they were MOG. And also their clinical course is not typical for MS. The brain lesions also don't look typical. So we have them reclassified them as MOGAD. I hope that answered the question.
Thank you. Yes. So your suggestion would be this adult cohort to with these symptoms from the onset in the pediatric age, you would classify them as pediatric onset MOGAD? I don't know.
It would be difficult, like if for example, if they had like one event like 20 years ago, and now if they're presenting with very typical symptoms of MOGAD, you could say that it's still like very unusual to go for 20 years without any other event. I would try to ask like more specific questions to find out if there were any other concerns or of a milder relapse that happened that was subclinical, or they didn't make it to the clinic and now they're having this other event, or like maybe MRI could be helpful to compare if they obtained it at multiple times to see if they had lesions to explain some of these symptoms.
Mhm. Thank you. Okay. So thank you everybody for connecting today. We had very nice presentations today. We invite you to go to the new iWiMS page so you can reconnect with all of us, and we invite you to our next session on February 26th. And please enjoy your holidays.
Thanks very much.
Thank you. Bye-bye.
Thank you for having me.
Thank you very much.
Thank you for having me.
And thank you for getting up so early, Alice.
That's all right. That's all the fun.
Bye.
All right. Bye, everyone.
Bye.